Camera cover or something.
Sir, he wants to use it sterilely, can use it as such.
As such?
Use it, clean it up and use it, sir. Wait,
This is it.
मैं बोलूँ wet करने के लिए, sir. Can you
हाँ.
go live now?
हाँ, I'm ready.
Sir, I'm asking him to go live, sir.
Yeah, please.
Hello, Dr. Divesh, can you hear me? Dr. Divesh, can you hear me? Dr. Divesh, can you hear me? And Dr. Divesh, can you hear me? Good morning all. We are coming in from the OT. So can I just interrupt you because we have one case and 2 blocks lined up. So, okay, fine. So here we have a 27-year-old male for lap cholecystectomy. And we will be showing you rectus sheath block and EOI, external oblique intercostal block in this patient. The patient is under GA and Dr. Shishir sir and Dr. TVS Gopal sir would be demonstrating both the blocks, EOI and rectus sheath block.
Good morning. Am I audible? Dr. Anshuman, Dr. Divesh, am I audible?
Yes.
And this ultrasound image is visible?
Yeah. The needle and the probe.
And probe, yeah. So let's start with scan. We are scanning with the tap plane. You can very well see external oblique, internal oblique and transverse abdominis muscle. Okay. Internal oblique is the thickest muscle. Now I will move my probe relatively medial, just above the umbilical level, because maximum pain is at the periumbilical area after this laparoscopic cholecystectomy. So these are the tap muscle planes, and here you can visualize there is a curvilinear linea semilunaris, and medial to this linea semilunaris is it is the rectus muscle. Okay, it is covered by the rectus sheath, anterior and posterior as well. So just below the rectus muscle, there is a tam track appearance. You can see 2 fascia there. There are 2 fascias. One is the posterior rectus sheath. Another is fascia transversalis. And just below this, there are some moving structures, which is the viscera and peritoneum is moving. So you got it. You can see this muscle, and when I am going medially, you can see linea alba. This is linea alba, linea semilunaris and posterior rectus sheath. So before giving my final injection, I want to see is there any inferior gastric artery, inferior epigastric artery. Sir, can you put the color there? So yes, it is not in my field basically. So now I can go forward. I have chosen a high frequency probe and 5 centimeter needle. For drug, I have taken 0.2% ropivacaine along with slightly slightly 1. So halt कर लेते हैं सर. So in longitudinal plane, you can see the rectus muscle. There is a tendinous band going further upward. One more band. Now it's around, we are around the Ziphy sternum. Okay, now there is an insertion over the rib. This is around T6 or 5, T6 and T5. Here this muscle is inserting. Okay, now moving my probe relatively lateral. Okay, so these are ribs. 6, I hope 5th and 6th rib. And this is the external oblique muscle. This is external oblique muscle, and beneath that is the intercostal muscles. So now going to demonstrate external oblique block. So you can see there is some vessel there. I need to avoid this vessel. So probe is basically oriented toward the axillary line. Probe is oriented in the axillary line, slightly tilted probe towards the axilla, and everything.
Hello. Dr. Sisi sir.
Yeah, opposite side.
Dr. Sisi, can you hear us?
Yeah, now, yes, please.
So the thing is, sorry to just interrupt you because we lost the transmission from the OT because of this glitch, technical glitch. Can you just show us again the rector sheet? Yeah. And we have the pointer here, and Dr. Manish will be doing that pointing thing. So you just proceed with the scan, and whatever you are speaking, you will be showing to the audience from here using the pointer on the screen. Right?
I have chosen a high frequency probe, straight probe, and I am scanning abdomen. Just see, there are 3 muscles: external oblique, internal oblique, and transversus abdominis. Now going relative medial, and you can very well visualize a semilunar structure, which is the linea semilunaris. And muscles medial to this is the rectus muscle. This is the rectus muscle. Okay, now again this curvilinear structure is the linea alba, where it is merging with the opposite side of the rectus muscle. This is the linea alba. Okay, so this rectus muscle is covered by the rectus sheet. You can see here, this is the anterior rectus sheet, and there is below down it is the posterior rectus sheet, and beneath this posterior rectus sheet there is fascia transversalis. So it is looking just like tram track or railway track appearance. Below this fascia there is a moving structure which is peritoneum. So I will put some color before giving my final injection. Most of the time you will get inferior epigastric vessel, and very often in the basically, yes, it's very big, but not in the plane. Yeah, I think it is aorta. It's aorta. So please, now needle will be from lateral to medial. Yes, my needle will be from lateral side to medial side. I have chosen a 5 centimeter needle. Cross orbital palm. So my needle is coming and piercing rectus muscle, and now it's just above the posterior rectus sheet. Yes, yes,
I'm just pushing 0.2, 0.5 ml,
yeah.
1 ml.
Drug is spreading over the posterior rectus sheet between the epimysium of the rectus muscle and the epimysium.
1
And
ml given.
yes, sir, we'll proceed with the rest of the drug, please. Now you can visualize the spread of the drug.
Intermittent aspiration negative.
So it is around 10 ml in this patient, each side. each side. Basically, we need to give block, we want to block only peri-umbilical area.
Shall I remove the needle?
Yes, sir, please. So you can see after my longitudinal placement of the probe, you can visualize the rectus muscle and beneath there is a drug and there is a band in between. Sometimes this band inhibits drug spread cephalocaudal or caudal to cephalic, and there is another band when we move forward. This is another band. Yes, this is the longitudinal scan. I am moving cephalic, and now you can see the muscle is some bit dense. So now you can see it is inserting over the rib. You can see this is the rectus muscle. It means this is C5, T5, T6 level. Now moving further laterally towards axilla, slightly, my probe is slightly oblique, and you can visualize external oblique muscle there. And below the external oblique muscle, between the ribs are the intercostal muscle. Idea is to open this plane. In books, it is mentioned injection should be cephalic to caudal, but for my ease of insertion, I am choosing caudal to cephalic. Sir, can you give
As
1 ml?
position is negative, I am gently giving the local anesthetic. Yes, that's the perfect spread. Perfect spread.
So now this plane is opening up and drug is spreading.
3 ml given so far.
I've given 3 ml so far with intermittent aspiration, that is negative. You can see the plane between the external oblique and external intercostal muscle. It's beginning to open up. And you can see the spread going over the rib as well. So it is advised that this block be done between the 6th and 7th ribs, and about 20 ml of local anesthetic be injected in this plane. And it has been postulated that both the lateral as well as anterior cutaneous branches of the intercostal nerves will be blocked. So you have better analgesia for subcostal incisions in between the xiphisternum and the umbilicus when compared to a subcostal tap. Because the subcostal tap is technically a little more challenging. Here the endpoint is much easier. You are targeting the interfacial plane between the external oblique and the external intercostal muscle. So here we've injected 20 mils of local anesthetic. With that, we have completed the external oblique intercostal interfacial plane block.
So, see drug spread.
Dr. Girish, I don't want to interrupt Dr. Shishir, but what he rightly said, that we have the needle from the normally from the cephalic to caudate direction. So in this particular patient, I think it is done from caudate to cephalic. Like for audience, how to explain this?
Because I am a right-handed person. Anyhow, it is an interfacial plane block. So it doesn't matter whether you give cephalocaudal or caudal to cephalic. Drug should be in right plane only. Drug should be in right plane only. So for me, because I am a right-handed person, it is easier to go caudal to cephalic. According to your ease, you can do. I Ultimately, this whole pain will open up with the 20 ml of the drug. It hardly matters. In this area, we need to block T6 subcostal area, T6, 7. So ultimately, all 3, 4 segments will be bathed with the drug volume.
I think it is just for this particular lab only that is done like that. So what should be the technique of giving the drug in this range? Are there typically dosing that the patient will work in slow dosing?
Thank you.
Hello, Dr. Divesh. Yeah, we can restart the master class. So we're shifting the patient out, and when we get the next patient ready, we'll give you a call. And sacral plexus block in this patient.
Good morning, Divesh. Good morning to all the delegates and the rest of the faculty members sitting in the hall. As Anshuman said, he is a young ASA1 patient with a huge wound on his left foot. He will be requiring rather major surgery in terms of a flap cover. So in this person, we planned lumbar and sacral plexus blocks. I apologize, you don't see the landmarks that I have marked on the patient's skin. This is the posterior superior iliac spine, and that is the line which is drawn superiorly from the posterior superior iliac spine. This is the L4, L5 interspace, and the insertion point for the needle would be at the junction of the medial 2/3 and the lateral thirds of a line joining the interspace to this line which is going superiorly from the PSIS. Now for the sacral plexus, we drop a line which goes 6 centimeters distally, and this is the insertion point of the needle for the sacral plexus. And this typically corresponds with the commencement of the intergluteal cleft. Now, when I do a lumbar plexus block, this is a fairly deep block. It's a profound block. It blocks all the branches of the lumbar plexus. So you're looking at 2 branches that arise from one root, which is the ilioinguinal and iliohypogastric. You're looking at 2 nerves that arise from 2 roots, which is the lateral femcutaneous nerve of thigh and the genitofemoral nerve. And you're looking at 2 nerves that arise from 3 roots, which is the femoral nerve, which is the largest branch of the lumbar plexus, and also the obturator nerve, which typically lies in a different compartment. So I have placed my needle here. The patient is under GA. He's had an IGEL in place, and no muscle relaxant has been given. I've connected this 100 millimeter insulated block needle to the peripheral nerve stimulator. I have it at 1.2 milliamperes. The pulse width is 0.1 milliseconds, and I have him on 2 hertz, which is the frequency. So I'm just going to introduce the needle towards the transverse process. Now the distance from the skin to the transverse process could vary depending on the body habitus of the patient. This guy is quite huge, so I would expect the transverse process to be quite deep. And once we touch the transverse process, the idea would be to walk off the transverse process to be within the psoas major muscle so that we elicit the contractions of the lumbar plexus, which would be in the form of a quadriceps contraction. Wait. Can I just open this up? This is more likely to be a local contraction. Now I am on the transverse process. He's quite a big patient. So I'll try and walk off the transverse process now. You can do it either cephalad or caudad. So I will try going cephalad now. Can we increase the current a bit? This is a fairly deep block and a rather profound block. So what I see here is a local contraction of the erector spinae muscle, which we must disregard. So now I am actually on the transverse process. So I'm just trying to walk off the transverse process to see if I can enter the psoas major muscle, and the lumbar plexus exits at the junction of the anterior 2/3 and the posterior third. See, now I've got the quadriceps contraction. I'm going to ask Shiva to reduce the twitch. The patient is not totally anesthetized, which is why we are having a problem. I'll just try and stimulate once again. Okay, see that? That's the quadriceps contraction. Since the patient is still quite awake, see that? That's the quadriceps contraction. I think you have seen the quadriceps contraction now. I'll ask Amjad to go ahead and inject the local anesthetic.
Sir, very well appreciated. We can easily make out the quadriceps dance.
Yes, there it is. Okay, the moment Amjad starts injecting, what you will see is that very soon the contractions will cease. And that would be the positive Raj effect. The positive Raj effect, initially they believed that, please go ahead, we'll give about 15 mils. They initially believed that the local anesthetic was displacing the nerve from the needle, but actually what happens is, as you inject the local anesthetic, it being a conductive solution, it increases the conductive area around the tip of the needle, and with the result that the density around the tip of the needle falls. So you need a much higher current to get the same stimulus as you would. So that is the positive Raj test. Amjad has injected 10 mils. I'm going to ask him to inject another 10 mils, and while he does so, I am going to scan and see whether we will be able to appreciate the spread of local anesthetic. You can see the darkish local anesthetic that is spreading just above the...
We do not have the ultra, yeah, right now.
Can you see that? You see that's the transverse process. You see the body of the vertebra below, and you see the darkish local anesthetic that is spreading just around the exiting lumbar nerve root there. And that's the local anesthetic. So Amjad has injected around 20 ml of local anesthetic. So can you appreciate that spread of local anesthetic?
Yes, sir. We can appreciate the spread of the local anesthetic around the lumbar plexus.
Yeah, all right.
And
So
what is the concentration you have used, sir?
I've used 0.25% bupivacaine. We've injected 20 mils into this area. So now you can see the lumbar, the root take off there, and you can see the plexus move laterally within the belly of the psoas muscle. And you can see the local anesthetic, that hypoechoic shadow that has come around the lumbar nerve root over there. would be the local anesthetic, that is the point. So what Amjad is showing you is the articular process view. Here you do not see the transverse process. So this is very, very close to the intervertebral foramen here. And as he moves his probe, you will be able to see the transverse process come into view. That's the body of the vertebra. That's the transverse process that has come into view over there. I'm just withdrawing my needle now, and I'll see if I can do it under vision. Not really. What we'll do is, the local anesthetic is a conducting solution. So even saline is a conducting solution. Since I don't want to change this needle and use a new one for the sacral plexus, I'll ask Amjad to flush the needle and the injection port with 5% dextrose solution, which is a non-conducting solution, so that we can use the same needle also for the sacral plexus. This is a fairly advanced level block. It is definitely not for the beginners, and it is a deep block, and there is a huge potential for complications with this block. You should know where to stop the needle. The distance from the skin to transverse process depends varying on the body habitus of the patient. But once you touch the transverse process and you start to walk off the transverse process, you should be able to encounter the lumbar plexus at a distance not more than 2.2 centimeters.
Sir, there is a question from the audience.
Yes.
When performing both the blocks, do you like to add some additives in the form of adrenaline?
I don't. What additional benefit would that give? In case you're in the intravascular compartment, you would have unexplained tachycardia. Is that what you're trying to say?
No, the audience wanted to know, because we are going to use a generous volume in both the blocks.
40 ml of 0.25 is staying very well within the limits.
Does that answer your question, sir? Thank you, sir. Please proceed.
Thank you. So this would be my insertion point. This would be the parasacral block of Mansoor. Now this is the PSIS here, and 6 centimeters distally over here, this would be the insertion point for my needle. And when I do this, I'll set the PNS at 1.2, please. 1.2, 1.2, please go up, please go up, please go up. And please go up to 1.2. And the lower limb is actually in a bandage casing. So we should be able to see the contractions of the foot actually. So this again is a fairly deep block. Sandeep and Abhijit had actually published a paper in which they said that if there is contraction of the gluteus, then you are in the right path. And they said this is the gateway to heaven. So can you see that twitch of the gluteus right here? It's a small twitch of the gluteus, which I can appreciate on my hand. And now we move posterior to the gluteus. The sacral plexus exits under the piriformis from the greater sciatic foramen, and it travels over the superior gemellus, the obturator internus, and inferior gemellus before it makes its way in between the gluteus and the quadratus femoris muscle. Now that is the dorsiflexion. So I am probably, that is eversion and dorsiflexion. So I am probably stimulating the peroneal component of the sciatic nerve. The sciatic nerve, right from its origin, is two separate nerves that is encased within a single sheath. So he is reducing it. He's gone to 0.6 now. We'll go down further. We'll go down further. Okay, at 0.4, I'm going to ask Amjad to inject. So this is a sacral plexus block. The sacral plexus block again is a profound block. It blocks not just the sciatic nerve, which is the largest branch of the sacral plexus, it also blocks the superior and inferior gluteal nerves, the pudendal nerve, and the posterior cutaneous nerve of thigh, which is a purely sensory nerve that innervates the area overlying the hamstrings. So you can see that the block is still persisting. So this is sometimes a challenge. So what I will do is, now the twitch has stopped. Amjad has injected about 8 mils of local anesthetic. I'll ask him to inject a total of 20 mils of local anesthetic here. And once he is done with that, I will move on to doing a scan. Devesh, could you appreciate the twitches?
Yes, sir. Very well seen, sir.
So when you stimulate the peroneal component, you get either eversion or dorsiflexion. So the mnemonic is PED. And when you stimulate the tibial component, you get inversion and plantar flexion. So the mnemonic is TIP. It is TIP or PED.
So which according to you, sir, should be
The acceptable twitch as per Mansoor, who devised this block, is also a hamstring contraction. But when you do a sciatic nerve block individually, you would always target a twitch that arises from stimulation of the tibial component, which would be plantar flexion or inversion. All right. So we've injected 20 mils of local anesthetic. I'll do a scan here. Now this would be the parasacral parallel shift. Now this here is the PSIS. This would be the greater trochanter. Now if you join a line connecting the greater trochanter to the PSIS and you drop a line here at the midpoint and you place your probe in this manner overlying this line. Now what you see there is a continuous line, straight line of bone, which is the,
ultrasound image, right?
yeah.
We are seeing the skin surface.
Can you see the ultrasound image?
Yeah, we can imagine.
Now where Shishir has put the arrow, that is the ileum, which is a continuous line of bone. And overlying the ileum, right from the skin downwards, would be the skin, the subcut tissue, the gluteus maximus, the gluteus medius, and the internalmost muscle would be the gluteus minimus. Now I am making a parallel shift towards the patient's sacrum in this manner. And as I start doing this scan, you will see that there is a break in the bone there. Can you see that, Devesh?
We can appreciate, sir.
Yeah, can you increase the depth, please? Can you increase the depth? Yes. Now there is a break in the bone there. Now, this is where I would expect to see the sacral plexus coming off. You can actually see two bones. One would be the posterior border of ischium, the other would be the sacrum. Now, just underlying the gluteus maximus, the hypoechoic muscle where the arrow is placed, that is the piriformis. Now, underneath the piriformis, you see the local anesthetic that has spread. And just underlying the local anesthetic is the sacral plexus. Now, if you look at the sacral plexus very closely over there, you will see a tiny pulsation, usually of the superior gluteal artery, which would be a marker for your. So it's not often seen, but that is usually a marker. And below that, if you see that hyperechoic fascial line, that is the peritoneum, below which you have the rectum. So this is quite a profound block. You need not be doing this unless you have sufficient experience, because the risk for complications is very high. Now, having identified the sacral plexus, I'm just trying to align the probe with the long axis of the sciatic nerve. So that would be the long axis. If you see the sciatic nerve, not so easy to pick up always. In long axis, that is how it would be seen. Okay?
So there's a question from the audience.
Yes.
If we have to give a combined number and sacral plexus block for
Yes.
the purpose of anesthesia for this patient,
Yes.
so would you like to use the same volumes and the concentration, or there would be some change?
I typically do all my high-risk elderly patients for hip fractures with lumbosacral plexus blocks. In my institute, we have done at least 500 patients with lumbosacral plexus blocks who've come for either a hemiarthroplasty of the hip or a PFN or a DHS.
So what is the typical cocktail you use, sir?
I use 0.375% bupivacaine, and the total ml, volume I go for would be again 40 ml. I won't cross that.
20 ml in each plexus, sir.
In each plexus, yes.
Does that answer your question? Yeah. So he uses 40 ml of 0.375% bupivacaine, 20 ml in each plexus. If you wish to use for analgesia, you can drop the concentration.
Switch.
Otherwise, what is recommended?
Yeah, please.
Hello, Dr. Divesh. Yes, we can start the master scanning. Just to give a brief thing, I just wanted to let the delegates know that the cases were planned in such a by the surgeons. So we do not have the luxury of just showing the upper limb and then going to lower limb. So the next patient that we are getting is getting for a shoulder arthroscopy we'll be giving you. We'll take 10-15 minutes. You can go ahead with a live master class, and we'll again connect with you from OT once we get the patient ready. Is that okay? Thank you, thank you, thank you. Please start the master class. Hello.
Get the machine closer, I can show you better. So this group, so I'm going to scan, you can see.
Hello.
This group watch on
We
it.
have now this 42-year-old lady who has a tear in the right side
Okay,
shoulder,
fellow will come
and
as
she
I
has
scan.
come for a shoulder
Coming up and
arthroscopy.
then saying
So
here.
usually
So we'll
these
inject here
patients
so that you can see a
do
good
not
hypoechoic,
have a long stay at hospital,
at a
and
level
our
of
plan is
C4.
to do the procedure and
C4.
send them back ASAP.
On top of that, this
So
group, I'll just
Dr.
get him little towards the
Shiva
lateral side at this
and
level.
Dr. Amjad
Okay.
will be now showing you a scut block. We'll go live when I'll tell you.
Anshuman sir, there is a small technical glitch. We can't see from the operation.
Yeah, we have stopped the video feed right now. We will start video feed soon. I am just giving a planning about what are the cases. We are good to go? Okay, fine. We can start the live from OR. Start.
So now,
We can start the live.
good morning. Devesh, can you hear me? Hello? Yeah, Devesh. So, yeah, okay. Now you can see the ultrasound as well. So now as you demonstrated in the morning, you can see now the sternocleidomastoid muscle on top, the internal jugular vein, carotid artery, and then we are coming lateral to identify the interscalene groove. Now you can see the anterior scalene muscle, on this side and the middle scalene muscle on the lateral side, and you can see the hypoechoic structures sandwiched between the two scalene muscles. So those are all the brachial plexus element. As today morning Divesh demonstrated, we are going to scan above and down and see how these hypoechoic structures are going to originate from which structure. So I am going to scan up. You can see now the round hypoechoic structure is disappearing into a bifid cervical transverse process. So you can see the anterior tubercle is very prominent, and then the posterior tubercle is much smaller. So this is a C6 cervical vertebra, and the root is very big. You can see very well, the size is very big. On top of that, you can see the C5. The C5 is very small, and the C6 is very big. So now as I scan up, you can see the C6 has disappeared. As I go up, the C5, which is a very small round structure. So this is a C5. You can see the size of the transverse process of C5, which is very small. And as I come down, you can see the size of the C6, which is very big. So that is how we will identify C5 and C6. As we scan down, you can see the C5 and C6 joined together form the upper trunk. So now all the three C5 and C6 join to form the upper trunk, and it has become a single group. As we go down further, you can see the upper trunk is dividing into posterior division and anterior division, and then the suprascapular nerve is falling out of the uppermost lateral aspect. So that is the suprascapular nerve. So that is a SPA arrangement. So this is the suprascapular nerve, posterior division, and then the anterior division. So this is the SPA arrangement. So now this is the upper trunk demonstration, and now we are going to look at the supraclavicular nerves. So if you see, this is the anterior scalene muscle, that is the middle scalene muscle, and you can see the white layer on top is a prevertebral facial layer. And similarly, if you look at the sternocleidomastoid is covered by the investing layer of the fascia. So between these two fascia, the investing layer and the prevertebral layer, you should look for the supraclavicular nerves. So now if you see some group of nerves or looks like a supraclavicular nerve where Shishir is focusing his arrow, I am going to scan up and see how they are moving. Now they are moving towards the midline. So they are likely to be the supraclavicular nerves. So if you have these sort of targets, you fix them up and then give a local around them, then you can appreciate them well with a hypoechoic local anesthetic. Since it's a very superficial block and then the targets are very small, I am using a 26 gauge our conventional hypodermic needle connected to a 10 ml syringe. So I am going to use an out of plane technique. So we are using only a 0.5 percentage. So now you can see my needle is just coming out of plane and then dropping just on top of the target what we are trying to give. So you can see my needle tip is just coming close to the target. Now I ask Amjad to inject just 0.5 ml and see how the Amjad 0.5 ml. So 1 minute, I will just wait. Yeah, now inject 0.1. You can inject little more, as a boluses of 0.1, 0.1, 0.1 ml.
So, Dr. Shiva, where are you injecting right now?
So now I am just close to 3 o'clock position of the supraclavicular nerves. You can see my needle tip is coming there. Now that is my needle tip.
Yes,
inject.
we can appreciate.
Yeah, can you inject little bit more? So now you can appreciate the targets well, it is floating up. We are injecting as a 0.1 ml increments. Our plan is to deposit only 2 to 3 ml close to the nerves. So I withdraw my needle and go little more closer to the nerve. Inject.
Can you appreciate this?
So now I will come out and then scan. Now you can able to, with that hypoechoic, can you point out seizure? So that group is the supraclavicular nerve group. So that whole group is the supraclavicular nerve group. So now as I scan up, it will come medial, and as I scan down, they will become more superficial and split into the smallest branches. So that is the supraclavicular nerves. So how much ml has gone, Amjad? So now I am going to deposit little more. So this time I'm coming to the other side of the nerve, exactly on top of the target. Can you give 0.1 ml? 0.1, 0.1, 0.1, 0.1, 0.1. So that is we are exactly depositing within the cluster of the supraclavicular nerves. 0.1. So now almost 2 ml is over. 2.2, 2. Okay. So you can see the whole supraclavicular nerves are swollen up. So another 0.5, 0.5, 0.5. Okay, right, fine. So now 3 ml of local anesthetic has gone now. So now this whole group is the supraclavicular nerves, which has been between the prevertebral layer and then the investing layer of the deep cervical fascia. So this group is the supraclavicular nerve. That is the area where we will look for. So as we scan up, they will become individual branches. So this is one branch and that is another branch. As we go up, they will become grouped together, and as we scan above, they will migrate medially. So that is a supraclavicular nerve injection. Now we will come to the upper trunk injection. So increase the depth. So now we can see the C5 and C6. The C5 is on top. That's a C5. Now C6 has become bifid. So this is what we are initially called as a traffic light. C5, C6 divided into 2. So now as we go down little more, you can see all the three things are together and they are about to divide into anterior and posterior division. So now I am going to use the same needle. So we have used 10 ml syringe, 3 ml we have given for supraclavicular nerve. The remaining 5 ml we are going to deposit for the upper trunk. So again I am coming out of plane. You can see the tissue movement, so that I can drop my needle just in the hyperechoic connective tissue matrix. Now I'll request just to inject 0.2 ml, 0.2. You can see the trunk is swelling up a bit, 0.2. Since we are using a smallest, I'm using a 26 gauge needle, and we wanted to inject in a smaller increments, 0.2, 0.2, 0.2, and appreciate the whole trunk is getting swelled up, 0.2, 0.2. Keep going, 0.2, 0.2. You can see my needle tip is on one side of the trunk, 0.2, 0.2. So how many ml has gone, Amjad? So 2 ml is gone now. We can stop. So with the 2 ml itself, you can see the trunk is, initially the trunk itself is swollen up. So that is an upper trunk. Now as we injected a local anesthetic, now you can see the division has been splitting into two well. Somebody can pull the elbow down, little bit traction. Gentle, yes, that's great. So now you can able to appreciate the spa arrangement clearly. So that is the suprascapular nerve, this is the posterior division, that is the anterior division. As I come up, all the three things are together. So now we have given almost, take out the arrow. So again you can see the tissue movement exactly on top of the trunk and then coming little lateral to it, 0.2, 0.2, 0.2. Because we are giving very small increments because we don't want the local to seep all around, 0.2. You can see the needle tip moving within the upper trunk, 0.2, 0.2, 0.2, 0.2 ml. So that you're appreciating the local is not going anywhere, only within the trunk. So that we wanted to deposit 5 ml of local anesthetic, 0.2, 0.2, 0.2. So I wanted to go little bit down so that the C6 also will soaked well. So now almost 3 ml has gone. We wanted to give remaining 2 more ml within the trunk. You can see my needle tip is on the bottom of the upper trunk. Below that is the middle trunk is there. You can see. So that is where my needle tip is there. This is the middle trunk and this is the upper trunk. Okay. Give. So you can see my needle is coming out of the trunk. Point two. If you finish 5 ml, we can stop. So 5 ml of local anesthetic is given into the upper trunk. Now I will just scan above and down and see how the local has been spread. So even if you give a 5 ml of local anesthetic, the volume is very less. See, even still the local anesthetic has come between the brachial plexus element and the scalene muscle as well. So this is happening even with 5 ml of such a meticulous small volume injection, but still the local has come all around. So this is how it will spread up. So I'm just yeah. So now I'm going to scan up and then try to look at where is the phrenic nerve comes in. So we wanted to look at the phrenic nerve in the anterior surface of the anterior scalene muscle. So we are scanning up to see where is the phrenic nerve is going up. So here already it has come up to here. So here that the phrenic nerve is at this level, the phrenic nerve is almost on to the most medial side. So if I come up, you can see that is migrating and then coming here. And then as I go down, you can see the phrenic nerve along with the ascending cervical artery, it is moving towards the medial side. So this is where we have given the local. The local has come little bit out of the trunk, but that is what is in reality is happening. This is even with 5 ml, this is the amount of spread that you are seeing. So that is the upper trunk now dividing into suprascapular nerve, posterior division and the anterior division. And below that is this is the middle trunk, this is the inferior trunk at the corner pocket. This is the first rib, and then the pleura is on the either side. Can you activate the arrow? So is there any other questions?
Yeah. Is this an analgesic block or an anesthetic block?
So here this is an analgesia block because the patient has got a supraspinatus tear and they are going to repair through the arthroscopy. But the C5 and C6 is going to supply to the shoulder almost 95%. So it is an analgesic block. If you wanted to anesthetize the entire shoulder, we need to block all the components. So this is for analgesia.
What is the concentration you have to do anesthesia, and in case it was an anesthetic block, what would be
So if you wanted to do entire arthroscopy only under a block, I need to do a full brachial plexus block plus a port site infiltration on the posterior side. So that is a different strategy altogether. So that time, depending on the situation, suppose if you have a 30 to 45 minutes to start the surgery, we can use only 0.5% bupivacaine. If you wanted to have only 15 minutes time, you can use an equal mixture. So here, since we are going to take a bit of a time, I have used only 0.5% bupivacaine so that she will have a very good pain relief for the next 8 to 10 hours.
Good morning. This is Dr. TVS Gopal once again from the theatre complex. Can you hear me, Devesh, and the other moderators in the auditorium?
Yes, sir, we can hear you, sir.
And I have with me a 61-year-old lady. She's got a history of CAD. She's got a PTCA and a stent placed in one of her coronaries. I don't have the particular. She's not on anti-platelet agents. She's had a fracture in July, which was treated conservatively involving her ulna, the right ulna. She was treated conservatively, and since there has been a bit of non-union, she's been advised the open reduction internal fixation for the ulnar fracture along with iliac crest bone graft. So in her, we will be doing the lateral sagittal approach to the infraclavicular brachial plexus. Now, as you can see, I'm standing at the head end of the patient, and my probe is placed just distal to the clavicle, and this is called the parasagittal placement of the probe. Now, if you see on the screen, at the top end would be the skin, the subcut tissue, And then you have the large muscle, which is the pectoralis major. And in the plane between the pectoralis major and the minor, you see a branch of the thoracoacromial artery. And the smaller muscle, that is the one on which there is an arrow, that would be the pectoralis minor. And you have the compressible axillary vein there. Siva has his arrow there. And then next to that, you have the axillary artery. And what you see is there is an aberrant vessel, an artery that's arising from the axillary artery. Now, just in between the axillary artery and the aberrant vessel, distal to the pec minor, you see the lateral cord. And the posterior cord is immediately posterior to the lateral cord, just immediately posterior, just below. That's the, yes, that's the posterior cord. And the medial cord would lie in between the axillary artery and the axillary vein. Now that where Shiva is showing the arrow, that would be where the medial cord is. Now you can have two approaches to the infraclavicular brachial plexus when you're using the lateral sagittal approach. One would be a single point injection by placing the needle just posterior to the axillary artery so that there is a U-shaped spread of local anesthetic. The other would be to target all three cords individually. So I will try and show an approach wherein we will target all three cords individually. So that is the needle that is being placed just distal to the clavicle. Don't push my hand. Yeah. Okay. I'm going in plane, and very soon you should be able to see the needle which will enter the substance of the pectoralis major. This is a blunt tip needle, so you need to exert a lot of pressure to be able to see to get the needle into the muscular plane. So I will be going first for the lateral cord. I'll just try and pick up the needle for you. It's a fairly steep angle. Can you just aspirate and inject a little, please? I just want to see where the tip of my needle is. No. So it's coming just posterior to the pectoralis minor. That's where the local anesthetic is coming. Okay, please inject now. Please inject now. Wait a second. I'll just try and pick up my needle first. I'll just try and withdraw the needle and reinsert it once again. I should be at the lateral cord now. Please aspirate and inject. See that drug? It is pushing the lateral cord up. Can you see that? It is coming just lateral to the artery. It's pushing the lateral cord up, and the posterior cord is also better delineated now. So I'll ask Sishir to inject about 10 mils of local anesthetic over here. Yes. Okay, just a minute, please. some more here, please. Now it's coming exactly posterior to the artery. I'm sorry, I'm not able to pick up the needle for you, but the needle, the spread of local anesthetic you can appreciate, right? No, it's not a U-shaped spread yet, but can you appreciate the posterior cord very clearly now and the lateral cord over there? And you can see the drug which is coming just posterior to the artery there. Okay, we'll just stop here. And I'll just try and, now can you see the lateral cord very clearly? That's the lateral cord. And the posterior cord is also seen very clearly now over there. I will try and go for the medial cord separately now. Picking up the needle here is not always easy. Aspirate and inject now. Yeah, now inject. Now inject. Inject. Yeah, it's coming there. Inject now. Yes, you see the drug coming in between the axillary artery and the vein. There. Okay, we'll withdraw the needle now. That's enough. So what I'll try and do is, I'm sorry I could not show you the spread of local anesthetic so clearly, but can you see the lateral cord so clearly now?
Yes, sir, we can appreciate.
That's the lateral cord. The posterior cord is actually here. Hmm? Okay. So that would be the posterior cord, just posterior to the artery over there. And the medial cord, if we just move the probe a bit, that should be the medial cord over there. Okay? So with this, we will move on to the fascia transversalis block, which is a block which targets specific. I have injected about 20 mils totally. 0.25% bupivacaine, because this is only for analgesia. The patient is under anesthesia. I thought this will be easier because she has to. Thank you. Now for the fascia transversalis block, you identify the plane between the iliac crest and the costal margin. And you start here by identifying the muscles. Can you just, yes. The muscle below the hypoechoic is the transversus abdominis, and the muscle above would be the internal oblique, and the muscle above that would be the external oblique, and above that would be your scarpa's fascia and the camper's fascia and the skin. So I am following posteriorly till such a point where I see the transversalis muscle end. That is where the transversalis muscle, transversus abdominis muscle has ended. And beneath that you see the intraperitoneal contents move, and lining the posterior border of the transversus abdominis muscle would be your transversalis fascia. So when you do a transversalis fascia block, you are actually targeting only the branches of L1. This is a specific block for analgesia following an iliac crest graft surgery. You see the needle going there. The idea of this block is to bring the needle outside the tap plane Can you increase the depth a little? Yes. And pop the transversalis fascia there. Yes. So now as Shishir gives the local anesthetic, you should see the transversalis fascia start to move upwards. Again, this is a very deep block. I typically do this in lateral position, but there it is. That's where the tip of my needle is. When I wiggle the needle, you can see the movement there. So that is where we will do the injection of local anesthetic about, yes, please inject, please inject. So that is the spread of local anesthetic just posterior to the transversalis fascia. So you inject about 20 mils of local anesthetic over there. Yes, please inject here. Yes. Yeah, now watch. Yes. Now we see a good spread that will come just posterior to the transversalis fascia there. So that is the whole purpose of doing the transversalis fascia plane block. You are blocking the branches of the L1, which is the ilioinguinal and ilioepagastric nerves. Yeah. So that I am just taking the needle out under vision. Any questions, Divesh?
There is a question, sir. Will this block work for a hernia surgery?
It should, because the ilioinguinal and ilioepigastric nerves, they ultimately supply that area. It should. But this was specifically devised for analgesia following bone graft harvest from the iliac crest.
So you have used 20 ml of 0.25% butylagen, am I right?
Yes, that's right.
Yeah, please run.
First is median nerve.
Dr. Divesh, Dr. Divesh, hello, Dr. Manish. Hello?
Underneath is the LACM. Okay? As I move laterally, can you see this structure? What is this nerve? Radial nerve.
Dr. Divesh? Yeah. Dr. Divesh, actually, we have got a patient who is a post-operative case of financial incision for LSCS. Usually in a financial incision, most of the time the blocks that are prescribed are posterior tap, ilioinguinal iliohypogastric, or QL. The problem with QL is that you need to make the patient lateral when you are making the entry from posterior to anterior side. So here we have a patient who is a post-LSCS patient. Dr. Shishir would be demonstrating in a supine patient with a wedge how you can place a QL block. So
going to demonstrate here QL block. Basically, it will be an anterior QL block, and it is a part of our routine practice. After every LSCS, we usually routinely give this cell block. So usually this block is recommended in the lateral position, but for the ease and to save the time of our OT, we usually give this block in supine position, and we place a wedge under the hip only, and position is like this only. We already prepared this patient, and this low frequency curvilinear probe is chosen. So like you can appreciate here, these are the abdominal muscles, and now moving my probe more posteriorly. So posterior to the, you can see where this marker is, there is a black tissue which is perinephric fat, and it is moving with the respiration. It looks similar to the QL muscle. So most of the time people get confused with this perinephric fat because there is a perinephric fascia as well. So I will move my probe more posteriorly, and now you can appreciate there is a muscle, triangular muscle. Okay, this is relatively depth. This muscle is quadratus lumborum muscle. और बड़ा depth. So now you can see QL muscle, psoas muscle. Now this is QL muscle. Below down is the psoas muscle, and posterior group of muscles are erector spinae group of muscles. So now moving my probe more posteriorly and slightly tilting my probe. So you can very clearly see now this muscle is looking relatively elongated. Okay. पेन हो रहा है? So my needle is coming. You can see my needle.
Yes, we can appreciate.
And now piercing this QL muscle. So just look here. Probe is slightly rotated to get more wide field of Anshuman, remove this arrow.
okay.
Okay, now just see this needle is hitting anterior thoracolumbar fascia. The idea is to deposit local, because this patient is breathing heavily. She is shivering. Okay, so please deposit few ml of the drug. So you can see this fascia is going down. You can see.
So basically, let me put it this way. This is the thoracolumbar fascia, and the needle is coming from this side. and you are depositing on the anterior aspect of the QL muscle. This is the anterior side, this is the posterior side.
Look here, this fascia is going down.
This fascia is going down, white color.
The idea is to deposit our drug between the this thoracolumbar fascia and epimysium of the QL muscle.
So this is our target. We should not cross this line.
Okay. So drug is already given. Just have a look. How is drug spreading into the fascia? Look, drug is just over the fascia. Okay. Can you appreciate?
Yes, sir, we can appreciate.
Is there any confusion? So how to identify this muscle with the perinephric fat? This fat usually it moves with the respiration. Look, this is moving with the respiration while this muscle is not moving, and this muscle is getting thicker as I am going down. Okay. That's all.
So Dr. Manish, now we will be taking one patient. So we have only 2 more patients for block over here. One patient we will be showing a paravertebral block, and the other patient.
Go to the nerve mode.
And as I do that,
MSK to nerve.
there is a break that is appearing in the bone. And there, now means exits the greater sciatic notch under the piriformis muscle, and in the vicinity of the sacral plexus, as I told
TVS sir,
this morning when we were doing the
TVS sir.
that there is a pulsation which you can see, which would be the superior gluteal artery. So that is
Sir.
the giveaway to locate the sacral plexus. And the hyperechoic fascial line towards the bottom of the screen would be.
Sir, TVS sir.
So this is
TVS sir.
like to do when you do what we call parasacral dilation. So I'm just going back.
Put some beta
Now
in.
you see the direct line, which is the idea. And as I
Are they replaying it or?
you will see this sort of a appearance. Right? So this is how you would identify the sacral plexus, which is the most proximal approach in the back of the.
Next one you need to wear a gown.
TVS sir.
Next is the catheter, isn't it?
Now, if you see this mark here, this line
What's the time now?
typically starts at the midpoint of the line that connects the greater trochanter.
Still 1 hour is there. Till 1 o'clock we have to do this.
And if you drop a line downwards by about 5 centimeters,
Gopal sir, can you, sir, just sorry for interrupting you, sir. Just as this has just begun, the sacral plexus that you have started showing, we have the patient ready with the thoracic paravertebral. Okay, thank you, sir. Yes, sir. Thank you, sir.
Thank you very much, sir. Anshuman, sir, you are on.
Thank you,
Hello?
sir. This is a
Divesh, can
yeah. So this is a young patient for lap coli, and we are posting showing the thoracic paravertebral. Patient is under general anesthesia, and patient is made prone. Dr. Shiva and Dr. Amjad will be showing you in paravertebral block placement. Thank you.
So, good afternoon.
The ergonomics and the orientation. of the
Divesh, can you able to see us?
patient. Yes, sir, we are able to see.
So
you.
patient is now is on prone position,
Yes, sir.
and I am standing to. Can you able to see us everything?
Yes, sir. Can
So
you
I am
please zoom out,
standing. Can you zoom out?
sir? Yeah, thank you.
So I am standing on the right side of the patient. My ultrasound machine is directly in front of me. So I am using a curve linear probe. So patient has been posted for a lap cholecystectomy. The plan is to block right side paravertebral block. So our idea is to block the greater and lesser least splanchnic nerve on one side. So the greater splanchnic nerves originate from T5, T6, T7, T8, and then the lesser one is T9, T10, T11, and the least one is T12. So if we block all these nerves on one side, that is going to supply the celiac plexus, which is the essential nociceptive zone for hepatobiliary zone. So if we cover the block from T5 to T12, it will take care of the parietal wall as well as a visceral pain relief. So in that way, this will become an effective analgesic block for laparoscopic cholecystectomy. So to do that, what we are going to do is I am using a curve linear probe. First I will identify, I am going to make 2 injections. So we are going to use 20 ml of 0.25% bupivacaine. 10 ml we are going to inject at T8. and then another 10 ml we are going to inject at T6, so that we will cover from T5 to T12. So that is the idea. So first let me demonstrate how I am going to identify the desired level. So if you look at me, I am placing the probe on the paramedian side about 5 centimeter from the midline. So in the screen, if you look at, the probe marker is towards the cephalad, and then the down hyperechoic shadow, what you are seeing is the ilial bone shadow. From there I am just going to scan up. So scan up, now you are seeing the lower pole of the kidney which is moving with each respiration. And as I scan up, the first rib shadow what you are seeing over the kidney is the 12th rib. Can you able to appreciate? You can increase the gain a bit so that they can appreciate it. Increase. So the shadow, the first shadow, rib shadow is a 12th rib. I am counting the ribs from there. So this is the 11th rib. This is 10. Now you can reduce the depth to 4 centimeter depth, reduce. So this is the 10th rib. So this is the 9th rib, and this is the 8th rib. So that is how we will identify. We already made a mark here. Can you able to show the mark? So already we marked here. So this is the 8th rib. At the 8th rib, I am going to do a transverse scan. So from the midline we can come. So now you can able to appreciate, reduce the gain, reduce. Okay. So on the midline, this is the spinous process. I am coming laterally. This is the lamina, and then the lamina ends up into the transverse process. This is the tip of the transverse process. As we come up onto the tip of the transverse process, I am going to slide my probe down so that the transverse process will disappear, and then you can see on this side is the lamina, this hyperechoic line is the lamina, and then the costotransverse ligament, the topmost white line is the costotransverse, superior costotransverse ligament, and the pleura is sliding down. So can you able to appreciate the wedge-shaped space? The superior costotransverse ligament. The first white line on top is the superior costotransverse ligament, and then the pleura is moving down. In between, you are seeing a hypoechoic space. So that is the paravertebral space. Can you able to appreciate?
Yes, sir, we are able to appreciate. And here, could you please remove the white line, the white?
Yeah, the center line, can you remove it? Can you remove that central line? Take off. Yes, okay. Now we will remove it. So, plant. Okay. So my needle is coming from lateral to medial in an in-plane direction. Can you reduce the gain a bit so that we can? Yes, okay, stay there. So you can see, appreciate my needle tip is approaching the superior costotransverse ligament. Because it is very close to the pleura, your movements are very minimal. You can see my needle tip is just scraping on top of the superior costotransverse ligament. I am going to pierce it. I just pierced. You can see it is very, very close to the pleura. Now I ask Amjad to aspirate and inject 1 ml of local anesthetic. Negative aspiration. As we inject, you can see the pleura is going down. Inject as a bolus. You can see the pleura is dipping down. So that is a clear surrogate mask. As it dips down, I will advance my needle little more inside further, so that my needle is well within the paravertebral space.
Yes, sir, we can appreciate.
So that is my needle tip in just against in front of the transverse foramen. So just on top of the pleura. Can you inject now? 5 ml has gone. 7, 8. Okay, 10 ml of local anesthetic has been injected. So now I am withdrawing my needle. So this is at the level of T8. So what we have to appreciate here is, if you see here, can you activate the arrow here? please concentrate here. So this is the lamina. So this is the transverse foramen. If I scan up, it will go to the transverse process. So you should not be injecting at this level. You should ensure that you miss the transverse process. So similarly, we will do the another injection at the level of T6. So we have injected 10 ml of local anesthetic at the level of T8. Now I am going at the level of T6. So similarly, activate the M mode, you activate M mode, yes. So now you can see this is the middle of the screen, this is the spinous process. This spinous process continue as a lamina, and then that lamina ends up into the transverse process. So first you have to identify this. Here also you are seeing one space. So this is a lateral costotransverse ligament. This is not superior costotransverse ligament. You should not inject here. If you inject here, the local predominantly goes to the intercostal space, not to the paravertebral space. So to go to the paravertebral space, I scan down so that I will miss the transverse process. So now you are not seeing the transverse process. If I scan up, you can see the transverse process. If I slide down, the transverse process will disappear. So this is the place you should target the paravertebral space. Now you remove the M mode. So now I have So now here you can see the pleura, and there is a white line on top of the pleura. That is a superior costotransverse ligament. Yes, that is a superior costotransverse ligament. So now again my needle is coming from in plane, lateral to medial. You know that this is an advanced block where you have to see the needle tip very well, otherwise you will pierce the pleura. So all the time the needle movement has to be very incremental, slow. I am just touching the superior costotransverse ligament and then piercing. If you have a doubt, you can inject 0.5 ml of local. Now itself you can see the pleura is dipping down. So already I have crossed the superior costotransverse ligament. You can see my needle is just on top of the pleura. Inject 1 ml. So now this pleural suppression is a clear surrogate marker of. So now as you inject 1 ml, 1 ml. As I created a space, then I can just need a little bit more inside so that I am well within the paravertebral space. Increase the depth a bit, Shishir. So 7 ml of local anesthetic is gone. It is very imperative that you should keep the needle tip always on. You can see the needle tip very clearly below the costotransverse ligament, just above the pleura. 8 ml of local anesthetic is gone. 9 and then 10 ml. So that is the another 10 ml injection into the paravertebral space. So now I am withdrawing the needle. So that is 2 injections, one at Gospies. So one at the T6, one at the T8 level. So 10 ml, so that we can effectively soak almost all the components of the splanchnic nerves which will contribute to the celiac plexus. So is there any queries, any other? Yeah.
Conventional thinking teaches us that we should identify the transverse process and then do the injection.
Yes.
Whereas you have been telling us that
Yes.
we should not inject when you identify the transverse process, and we should let the articular process move,
Yes.
at which there is no transverse process.
Yes.
Is there no danger that your needle could go a little too medial and you can have an epidural?
Yes, sir. So now here, if you look at in this image, so if the needle is, can you activate the arrow? So the exact paravertebral space lies in between the transverse process. So if you look at here, if you inject here, this will be very lateral. If I scan down, my injections will be here. So this is where exactly the paravertebral space lies. As you said, my needle stopped at this point itself. If somebody is not aware of this and goes up to this area, then it is likely the drug can go into the epidural space. So the medial most injection possible only when you miss the transverse process, then only you will arrive at the paravertebral space. If you inject lateral to the transverse process, the drug spread predominantly towards the intercostal space, so you will not get the longitudinal spread. So that is the disadvantage of injecting at the level of the transverse process rather at the level of the articular process. And at the same time, as you said, it is a medial most injections. You should be careful about going too medially where you can produce a vertebral, the epidural spread. Yes. So for catheter, Sisher is asked how you will place a catheter. The disadvantage of the transverse view is because it is projected towards the central neuraxis. So the chance of catheter going into the epidural space is higher. So whenever we wanted to place the catheter, we adapt an oblique view. What we will do is we will rotate the probe clockwise so that we will identify, we will use this particular view so that the probe is oblique, so that you will not go into the central neuraxis. It is a bargain between the pure transverse longitudinal view and then the pure transverse view, it's an oblique, so that the catheter will follow towards the head end. So for catheter placement, we will use an oblique view. For single shot injections, we will use a transverse view. Yes, in the same position. Epidural. So till that next case is ready. Fine. Yeah, thank you. Spirit.
Sir, Dr. Manish sir, can you hear me? Sir, we have one Dr. Manish? Just interrupting you, sir, sorry. You are ready here in the OR. This is a 57-year-old female for left side proximal humerus fracture. And Dr. Amjad, Dr. Shiva, and guided by Dr. TVS, sir, are planning to put a catheter. So over to you, Amjad. The patient is under GA. And over to you, Amjad, for the block details. Thank you.
Yeah, can you hear me now? Okay. So we have a lady for a proximal humerus, and we've already painted and draped, and if you can see, Shiva and I for a change are wearing the gowns today. This is because we're trying to place a catheter and we want everything to be pristine and sterile. Now if you can look at the patient, we're doing the left side of the neck. She's got a left humerus fracture. So this is the head, that's her chest, and I've already placed my probe on the neck. This is a high frequency probe. So you've been seeing this familiar picture on the ultrasound screen all morning. That's the carotid and the internal jugular vein. And I'm just going to swing my probe towards where the scalene is, and we'll just try to identify with clarity what the neural elements are. So straight away I'm seeing a rather large round hypoechoic structure at the center of my screen where the arrow is. Okay, I'm just going to move the probe a little bit to identify the bony landmark. So you can see that it's a bifid tubercles that it's coming out of, and one seems to be larger than the other. So this is clearly the C6 neural element that is coming out. If you look on top of it, there's another hypoechoic structure. We'll just try to get that in focus. You can see it coming down there. Again, going into a sort of a bifid arrangement in terms of the tubercle. So this is C5. So we have identified C5 and C6. When you're at the neck, one of the places that you would find that you would want to put a catheter is the interscalene cath. Now, the planning that comes into question here is where exactly are we going to put it and how are we going to put it. Now, if you look at this view here, this is probably where you would do a pure interscalene block where C5 and C6 are. But you also look at the distance from the skin to the neural elements. On the right you see the depth markers, and it's pointing to about 1 centimeter. All right, so this, if you approach these neural elements in an out of plane, how Shiva did the block a little earlier, then you would wind up with about just about a centimeter or a centimeter and a half of catheter inside. And this is why many of the interscalene catheters dislodge, and it's not a very popular place. People are always complaining that the patient moved the neck left and right and the catheter came out. So your next option is to look for a strategy where you could leave a lot more of the catheter inside and the tip of the catheter somewhere inside the interscalene groove. Here we are not very concerned, since you're putting an interscalene catheter, we are not worried about phrenic nerve blockade. This lady does not have any respiratory issues to deal with. So even if you wind up with a spillage of the local onto the phrenic nerve, it should not be a clinical problem in her. Now, as I scan lower down, we find that the C5 and C6 very quickly turn into this superior trunk there. All right, you see the middle trunk below, okay? And this, after the preliminary scan, this looks like an area where we could kind of fit in the catheter. We could come in from the lateral side and try to drop the catheter into the groove. If I go far lower, a little bit lower, you start seeing, yeah, you see the vessel there? That's a transverse cervical artery taking off. So let me just get, okay, yeah, so you see the pulsations? So this is a little lower down. So we have a very small, narrow window to work with. And this is probably where we should be trying to place the catheter. Now the catheter that I have with me is, Shiva, could you just place it? This is very different from the epidural catheters that we have, where we have a catheter through needle technique. This is a catheter over the needle. So if the camera can focus in, the main catheter assembly is actually loaded on top of the echogenic needle. So we will insert this entire assembly inside. Yeah, Shiva will just help me out. And then we will remove the needle and then push the remaining bit of this sleeve inside. And then there is another inner sleeve that comes in over here, which we will insert into the catheter. And subsequently, if Shiva can inject, this should be how it should work. And this part we will probably place 2 stitches in there and be done with it. So it's actually a soft floppy assembly that would be inside, and it should not be true traumatic. So this comes in later, and we will place this inside and lock it up. All right, so this is what goes in. We'll perform a little bit of a block before we'll hydro dissect the area. I think I put the thing the wrong way. And yeah, so if you can see, the bevel is up, the wire is down, so this is how we would be entering. All right. Okay, so that's what we saw. The artery is there, so that's an indicator that we probably should not be needling around over there. We go a little bit up. It's a very small distance. I'm hardly scanning 3 or 4 millimeters above to get into this zone. Okay, we've also placed a wedge under the shoulder of the patient just to give me some space. Now, if you're using a regular 2E needle, which is about 8 or 9 centimeters, then you would find that this is a useful maneuver to do to lift up the shoulder, because in case you need to go underneath or direct this way, you have some room to play with. Okay, so Shiva is giving me the needle, and we looked into the midoscalene. We don't really, there is some bit of hyperechoicity there where we're looking for the long thoracic as well as the dorsal scapular nerve, probably in that area there. Okay, not very clear, but we'll come in and we'll try to avoid those areas. All right. Okay, so needles in. Okay. I would probably have wanted to come in at a more steeper angle. Okay, so let's just move there. Okay, so I'm just going to try to direct my needle a little down so that the catheter slips through a little. Shiva, can you dissect in a little bit with a small bit of fluid? So you see that the needle is fairly well placed. How much have you injected? 0.5. Yeah, can we get another 0.5 in? Yeah, so you see that space is kind of opening. I'm not going to dissect too much. I'm just going to try to maneuver my needle in so that it doesn't move when we remove the assembly. Okay, so this, yeah. Yeah, yes. Okay, can you just help me undo this needle so that I don't lose? So here, all the while I'm having, yeah. So Shiva is going to remove that needle out of there, and let's see where. So you see the needle was tenting it up. Now the whole position has changed, but that's all right. We'll try to push it through at this point. So it's kind of moved. Kind of, yeah. Yeah, so it's kind of diagonal. Just can you just inject some directly in here? Yeah, it's kind of, yeah. Okay, inject, just inject. Yeah, yeah, it's on top. We'll just try to move it a bit before we. Okay, inject. Yeah. Okay. Okay. Put the assembly. So though we were between the upper and middle trunks, when we removed the needle, it slipped on above, but it's still in an acceptable position.
So Dr. Amjad, would you call it technically a superior trunk catheter or an interscaling catheter?
Well, once a local goes in, it can be anything. So once local is in, we don't know where it's going to spread. Okay, so Shiva is injecting. So yeah, this is a superior trunk catheter, as Dr. Gopal says. Can look to see if I can push it in a little bit more. Yeah, all right. Okay, inject. Okay, how much have we given?
We have given 5 ml.
Okay, we can give another 5. Yeah. So we'll also look in other areas so we can see where the artery was. That's where the catheter is. And higher up you see that there's fill all around. So this should be quite functional once we are having it fixed. Okay. So now if you look down at the skin, almost the entire cath is inside. So slippage would be minimal in this sort, and we will just take 2 stitches here and get it fixed. Okay. So at this point, that's where the cath is.
Here the ultrasound image, please. Yeah.
Alright, so this is where we will fix it, and you can see that the fill is adequate. It's around the upper trunk is actually quite well highlighted now because of the contrast of the local. Any questions, Devesh?
Any questions from the audience, please? Okay, so what is the volume and concentration right now you have given, and what is your plan for maintaining post-operative improvements?
Right, so this is, now there's no science to this, but this is visually a catheter that is close to the intended spill area. One second, just I get this. So we have given about 10 ml of 0.25% bupivacaine as the bolus. This should be fairly enough because you have a visual endpoint where the neural elements are bathed with the local anesthetic. In the post-op period, I would probably run an infusion that around 4 ml per hour, 3 to 4 ml per hour of probably 0.2 or even lower concentration of ropivacaine. That should be adequate. You can also put these patients on a PCA pump where they can control a bolus in case your volumes are inadequate and in the middle of the night they have pain. You can pre-program a PCA pump and have the patient press a button and get another 5 ml additional bolus to reduce pain.
One of the advantages of catheter over needle technique is that because the caliber of the catheter is larger than the introducer, which is removed after the catheter is placed, there is no worry that there is oozing of the local anesthetic from the insertion site.
मैं पकड़ तू पकड़ मैं डाल दूँ.
Yes, please, you can. We are just suturing the wings of the catheter. You may please resume your master scan, please.
Dr. Manish, I just want to give an interruption. I have put a poll in the delegates group, and there whoever are interested who do not have an conveyance for the radiation, please say yes. So please complete that poll so that we get a head count of how many people we need to take to Radisson. And after this, we'll be showing a prone epidural. That will be the last block over here. And then you can wrap up the AV this thing, the live demonstration. Thank you.
So the delegate will take his white phone, keep have him white phone, open the WhatsApp, and they will go into WhatsApp and cancel and share the PowerPoint. Thank you very much. And this capture technique is just clear that is a beautiful technique because we are in a process of the day. We have putting it together the capture that and testing out
Tight,
the
tight,
beautiful
tight
technique.
करो अच्छे से अच्छा.
The usually we give
नहीं नहीं okay.
to the holder today, that is a little bit. After that, we apply the pressure
Okay.
because there is a point which is
नहीं
about
नहीं ये टाइट है ये स्टिच थोड़ा लूज थे.
तो टीचिंग क्या कहती है, इफ़ यू डिपॉजिट द ड्रग इन द डिस्टल femoral triangle and a large volume of drug, a comfortably large,
Manish sir, can I just interrupt you for a second? Sir, this is the last, the resistance, as can say, but that's a patient. We have a young patient who had got a crushed foot, and we are planning to place an epidural in a prone position. So Dr. Shiva will be showing how do you place an ultrasound guided epidural. Usually what you do is to get the space marked by ultrasound assisted, but this will be USG guidance, and he will demonstrate to you and explain to you how he is going to do that. Over to you, Dr. Shiva.
Hi, hello, good afternoon. Can you hear me, Dr. Manish and Dr. Divesh? Yeah, okay. Now, see, this technique is going to be a new technique. It's not well established as of now. So it is going to be one of the new technique that is we are going to show to the delegates this time. So here we are going to do one real-time ultrasound guided epidural catheter placement. So here the patient is in prone position. This is an head end, that is a foot end. So we are going to do a lumbar epidural catheter placement. I am using a curvilinear probe which is going to fire from 1 to 5 megahertz. The probe marker is towards the head end. Whenever we do a longitudinal scan, we use the probe marker towards the head end. So I am going to scan from lateral to medial to identify the exact lumbar level. So if you look at it, what the shadow that you are seeing is the ilial bone shadow, what you are seeing now. I am just going to scan in the cephalad direction. So now you are not seeing any bony shadows. So as I scan medially, from lateral to medial, now I am just scanning slowly towards the midline. Now you can see the tip of the transverse process. Can you able to appreciate? So this is known as a trident sign. This is one tip of the transverse process. This is another, and that is another. So now here itself you can able to count. The lowermost one is a L5 transverse process. This is L4. This is L3. So now you can able to identify. Now I am arrived at L3 transverse process. So I am continue to scan medially. The L3 transverse process I am keeping on to the center, and I placed my M mode cursor over the L3 transverse process. So I am scanning lateral to medial, continue to scan, scan, scan. Now you see the L3 transverse process transformed into a superior articular process. So this is the superior articular process of L3 vertebra. So this is L3 transverse process. If I scan medially, it will transform into L3 superior articular process. After that, if I continue to scan little bit more, this is L3 inferior articular process, and this is the lamina what you are seeing. So from here what I am going to do is I am going to turn my probe, rotate the probe about 20 to 30 degree towards the midline. So I request the cameraman to focus here on the probe position. So can you reduce the depth? So reduce the depth. Yeah, stay there, stay there. So now when I turn the probe towards rotate the probe about 20 to 30 degree towards the midline, you can see the entire lamina that is ending up into the intervertebral foramen. Or I can come down to the lower space, yes. So can you appreciate it now? So slight adjustment of the probe to optimize the sonogram. So now if you look at my probe, it is about 20 to 30 degree clockwise rotated. So can somebody activate the arrow? So this is the lamina. Can you show that? And remove that line, central line. Remove that central line. Okay. This is the lamina. That is the posterior complex. This is the anterior complex. Devesh, can you able to appreciate? So it is. So now I'll come back and then scan again so that can you activate the central line, madam? M mode, yes. So now this is the transverse process. I'm going medially. So this will become a superior articular process. After that, if I go little bit more, you can see the interlaminar space. From there, you rotate the probe so that you see one complete full length lamina in a cross view. So you can see the lamina. Can you, Manish? This is the lamina. So from here there, that is a lamina that ends up in the posterior complex. So the space what you are seeing is between L2 and L3 interlaminar space. Put the stillet on. Can you remove the, switch off the M mode? Madam, can you remove the M mode and then remove the arrow also? Yes, thank you. Okay, right. So now I am going to introduce my needle from caudal to cephalad in line with an ultrasound probe. So already we have given a little bit of local there. So I just introduce our conventional 18 gauge epidural needle. So now you can see my needle is coming from caudal to cephalad angle. Can everyone appreciate the needle tip? So make a smaller adjustment so that you see the needle. So that is where my needle is there. So that is going towards the posterior complex. So after that I keep it there and then remove the stillet. What I am going to do is I am going to add up a saline. Leave it, leave that, leave it. Open, open. So I am just filling the space, close. Now you open it fully. So now I added 50 millimeters mercury saline bag loaded on in front of me. So now I have reached the ligamentum flavum and then I am going to advance the needle. As I announce, I can feel the resistance now. As I pierce the ligamentum flavum, okay, as I pierce the ligamentum flavum, I will have a loss of resistance feeling in my hand. At the same time, you can see the saline drip also will be flowing. Can you able to appreciate the saline chamber? Cameraman, can you focus there? My needle is exactly on top of the ligamentum flavum. You can see the jiggling of my needle. You can see the soft tissue movement there. Yes. Can you able to appreciate the ultrasound image? Little bit of jiggling just above the posterior complex. So now I am advancing my needle. I can able to feel the resistance. Advancing the needle, resistance, 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 loss of resistance. Stop. Can you stop the fluid, IV fluid? Stop. Yes. So now as I pierced the ligamentum flavum, you can see the saline freely flows into the epidural space. Now all the time I can keep the visibility on. Now I remove my probe, disconnect the saline drip, and then we can use the conventional, can you get a saline please? So now it is one single pass, precise L2, L3. You see the patient is very comfortably lying down. There is no movement, nothing. So it is very objective, precise, single pass epidural. So now I am using our conventional LOR syringe attached to the epidural needle. Aspirate, there is no CSF. Again forward flow, free saline flow. So this is how we conventionally confirm. Then we will place our catheter. So this is 10 mark, 11, 11.45. After that the catheter will go very easily without any resistance. So because we have already dilated the space with a bit of a saline. So that freely it is going inside. You can appreciate the angle of the needle. Can I get me the gauze piece? Can I get the marker? So now you can appreciate this is the midline. So the needle is going at this angle. So this is like a paramedian. So we have exactly marked L2, L3 interspinous space. We have exactly gone in between the L2 and L3. We have inserted the catheter in one single pass. So the entire, since we are coming on the paramedian route, you can see the entire needle is gone inside because we are traveling at a longer distance. So I am going to withdraw the needle. The catheter fixity also very good because we are going through the paraspinal muscles. The catheter stability also is very good. We got the depth at 8 centimeters. 8 plus 5, 13. So I keep the catheter at 15. So this is how the catheter will enter into the real-time ultrasound guided.
So, Dr. Shiva, can we have a look at the ultrasound screen? How does the catheter look? Is it possible?
Yeah, now it is very difficult to see the catheter, but again we will scan and then see whether we can see the dural displacement. So now I am just scanning from lateral to medial and going to the intrathecal space. Can you increase the depth, madam? Yes, madam. Thank you. No. One step down. You attach some saline and then keep it. I will tell you when to inject. Reduce the depth a little bit more, madam. So this is the best view that we can able to get because already that space has been distended with saline. So now, Shir, can you just inject? Yes, you can see now as we inject, can you see the air inject as a bolus? So now after that we were. Now? So because in the interlaminar space, we may not be able to see it. So it is, because, but you can see the air. Can you activate the arrow? So can you put a color? So this is where we are trying to look at. Give us a bolus. So only slight movement. We can apply a color and see. Can you apply a color? Take out the arrow. So now Sushir is going to inject. We will see the movement. Injects. Yes. So that is how we can confirm or then appreciate the drug is going at that particular place. So now we will, I'll just try to get the view because if we see the, here also the view is not very great. It may not be possible to appreciate unless we see a very good intertransverse view. Reduce the depth, reduce the depth. Yes. Yes, on the right side you can able to appreciate. Inject now. No. No. So here also because the window is not that great, it is very difficult to visualize. Okay, that is what is the real-time ultrasound guided epidural.
Yes, I think that was the last session that that we could nerve block we had. We can start the lunch. Lunch is ready. I request everyone to have your lunch, and we will start the panel discussion, the talk sharp at 1:30. Okay, fine. Thank you. Yes, sir. Sir, the credit goes to all the faculty who traveled so far and planned so meticulously. We could manage with more than 10 blocks, I believe. Thank you so much. Thank you.